Good morning. This is Dr. John Bennett from Miami, Florida. This is a continuation of the Conference for Neurosurgical TV, a series of presentations from neurosurgeons around the world regarding brain tumors. And today we have the pleasure of having Roberto Herrera, MD, a neurosurgeon from Clínica Belgrado in Buenos Aires. Roberto is a real-world traveler, and we're happy to have him here today. And we're also joined with Rick Reichert. We'll first introduce the panel, and then we'll turn it over to Roberto. Hello, Rick. You're muted, Rick.
Yes, no, not anymore. Here I am.
There you go. Yeah, Rick is from Belgium. He's a neurosurgeon. We just had a hangout with him about anti-epileptics and brain tumors. Welcome, Rick. And Slaven.
Hello everyone, my name is Slaven. I'm a medical student in Croatia and I'm looking forward to your presentation. Thank you.
Yeah, welcome Slaven. Okay, Roberto, it's all yours.
Okay, here in Buenos Aires, good morning everyone. I'm going to talk, and thank you Sean for inviting me to this conference.
Thank you.
I'm going to talk about our experience in Buenos Aires city. Buenos Aires is located in South America. It's a south area from of South America, under to Brazil, for example, for you know my country. And we work in Belgrano Adventist Clinic in Buenos Aires city. I'm going to talk about our experience in the last 12 years with intraoperative MRI and neurophysiological monitoring for removing brain gliomas mainly. This is our clinic, and this on the right is my team. This clinic is mainly for neurosurgery and cardiovascular surgery. The main objective to operate when we are operating a brain glioma is to achieve the maximal tumor resection with acceptable postoperative neurological dysfunction. We think the goal of the surgery is the main objective is to remove completely the tumor, preserving the neurological function in the patient. And for this, the intraoperative MRI and neurophysiological monitoring take a very important role. It's very important for this. Of course, the neuroanatomy knowledge is very important. As the new neurological studies, diagnosis methods are very important too. The high field MRI, the tractography, the functional MRI are very important to do a very good surgery, but the neuroanatomical knowledge is more important.
Excuse me, Roberto. Your slides are not moving. Do you want to? Right now, we see the slide of your clinic. Is that the slide you want?
You can see this slide now.
I can see the slide, the second slide you have. Do you want to change or no?
You can see.
I can see. I can see the clinic. The second slide. Which slide do you want to show?
You are seeing these slides?
Yeah, the clinic. The clinic.
Yes. And now?
Okay. ¿Está bien? La clínica es bien? Okay.
Now I showing the main objective.
No, I'm not saying that. We still see the clinic.
No, it's wrong.
Okay. Let's try to change this They changed. They changed. The main objective, yes, main objective.
Yes, but when we put big, you can see the main objective.
Yes, we can see the main objective.
Are you seeing?
Yes, I'm seeing the main objective.
Okay, this is the main objective: the maximal tumor resection with acceptable postoperative neurological dysfunction. I said this is the main objective of the in glioma surgery. Are you seeing these slides?
Yes.
Going to change the slides.
Yes, we are seeing the main objective slide.
And now?
Yes.
No, I changed my.
No, we don't see this. Yeah, we see it.
Okay, now it changed. It changed. Now we see the MRI, and we see.
Okay.
Yeah, we see the MRI.
You can see now.
Yes.
The anatomy.
Yes.
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 Okay. I said that the anatomy is very important, like the diagnosis, the high field MRI, the tractography are very important to do a good surgery. I'm going to change the slides.
Okay. Okay.
No.
Come on.
Yeah.
Come on. No, not. Yeah. Yes.
Okay.
Yes.
This is our operating room in Belgrano Dentist Clinic. We have an open magnet, 0.23 Tesla. This is the operating room. This is a big room. Here you can see the team working during an intraoperative control. We are checking the steps of the surgery. The patient is in position in the MRI, and we are waiting for the images. And this is a view of the operating room from the other side. You can see it. Hello?
Yes, we can see it.
Yes, we can see that. Yes, we can.
We see it.
Yes.
I changed the slides. You can
Yes,
see?
we see this as well.
It changed.
Patients and methods. Between November 2004 and May 2015, we operated over 300 patients with gliomas, brain glioma. And in 76 of them, located in functional brain tissue during the resection, we use neurophysiological monitoring and intraoperative MRI. And the goal of the surgery was maximal glioma resection with no permanent neurological deficit for the patient. I am going to show you some cases, for example. Can you follow me with the slides?
Yes, we can.
Okay. This was a patient with this glioma located between motor area behind and language area in front of. This is the tumor in flare. This is the tumor in T1 and located here. In front of it, the language area, and behind motor area. We use neurophysiological monitoring. Here, they are our neurologists. We made tractography. Here you can see the tumor and the corticospinal tract close to the inner area of the tumor, and functional MRI with Broca area here, with language area here in front of the tumor. We localize with electrocortical stimulation the area of the tumor. We can see it on the brain surface. This is MRI. We localize central sulcus here, and we define the tumor in this area. To confirm this, we put some marks over the brain surface. Here you can see the marks, and this is intraoperative MRI. Here you can see the marks, and this is the tumor exactly under the marks. And this is intraoperative MRI when after we removed completely the tumor. This is the patient after surgery, and this his MRI and functional MRI, preserving motor area here, the surgical bed after tumor resection, and this is the surgical bed after remove this tumor. We work with both things, intraoperative MRI and neurophysiological monitoring. This tumor was located in Broca area in a young girl, a young woman. The same procedure, marks on the brain surface. Here we can see the marks, the tumor on flare with the head open, and the intraoperative MRI after we removed completely the tumor. We tried to do an anatomical resection. We use intraoperative images to do anatomical resection of the tumor. And this is the patient after surgery. This is the MRI. This is previous and after remove the tumor located in this area. And the patient with any problem, no problem in her language. Could you see the slides and hear to me?
Yes.
Yes.
Okay, I following. This patient had oligodendroglioma, a low-grade glioma, but 1 year after her first MRI, this tumor take enhancement with gadolinium. We decided this tumor turn in high-grade glioma, and we operated this patient awake to preserve language area too. Here you can see on flare a very big tumor, and this is the intraoperative images with a good resection of temporal lobe with the tumor, and partially frontal lobe. Here you can see MRI control with the brainstem completely free. This is the postoperative MRI 28 months after our surgery. Another example, it was a very interesting case in a patient with 2 gliomas. A man with 30 years, which we consider multicentric oligodendroglioma. This patient had 2 tumors, one in right temporal lobe and the other in left parietal lobe. We decided to operate in the first time the temporal tumor, and we remove it completely. Here you can see the control after surgery. And 2 months later, we operated the parietal tumor. Here we use electrocortical stimulation to preserve the arm, and this is the patient 10 years post-operative after we could remove completely both of the tumor, and this is one of his last MRI. This patient is without tumor, and with completely normal life. Sorry, excuse me. This was a girl with a tumor located in frontal lobe, but here you can see the corticospinal tract, and the tumor very close to corticospinal tract. We localize the tumor with electrophysiological monitoring and remove it using this technique and intraoperative MRI. Here we are removing the tumor using subcortical stimulation to preserve the corticospinal tract, the motor fibers. And this is the patient a few days after surgery with slight hemiparesia, and several months later with complete recovery of her neurological function. In Wernicke area, we operate some cases with patient awake too. This was a low-grade glioma located in this area, and here you can see the patient awake. We localized the Wernicke area and removed the tumor completely. We could remove the tumor with preserving the Wernicke area and language function in the patient. We are using neuronavigation together with intraoperative MRI and neurophysiological monitoring, mainly in deeper located tumors. Neuronavigation is very useful to localize the pathology, and then we control it with images of MRI. This is another case with the tumor 2 located in premotor area, close to Broca area, and this is intraoperative MRI. You can see here a mark, a little mark in the bottom of the surgical bed, with complete resection of the tumor and the patient without neurological dysfunction and with very good language after surgery. In insular tumors, these kind of neuromonitoring and intraoperative images are very important too. We have operated more than 50 insular tumors in different grades of insular tumor. And intraoperative MRI is very useful for this surgery. Here you can see the surgical bed with middle cerebral artery with his branches, and this is the insular bed. This is the patient a few days and several months after surgery, and this is her last postoperative MRI with resection of the insular tumor. It was a low-grade glioma too. Our results in eloquent cortical areas and white fibers were we systematically detect and preserve cortical areas and white fibers. And despite these controls, we do 78% rate of immediate postoperative neurological worsening. The patients were worse, but 92% of the patients recovered their preoperative status within 6 months. When you are operating very close to an important area, an eloquent area, is probably that because we touch this area, the patient will have neurological dysfunction after surgery, but most of them going to recover the previous neurological function. Intraoperative MRI, we think, is useful to identify with precision functionally important brain areas and help us to preserve them. And the combination of intraoperative MRI with neurophysiological monitoring, we think facilitates tumor resection in eloquent brain regions. This is our concept. This is that we think, and we recommend in glioma surgery, especially, mainly in glioma surgery, to remove completely these tumors. We said to the patients, to the oncologist, that it is important to remove completely these tumors because we can accept treat a patient with partial radiotherapy or with partial chemotherapy. I can't accept to treat a patient with 2,000 rads of radiotherapy or with 1 month of temozolomide. It's necessary 6,000 radiotherapy and 1 year or 2 years of chemotherapy. Why we are going to accept to remove 0.5% of the tumor, or only a little percent of the tumor? I think neurosurgeon have to try to remove completely the tumor, and then we can use radiotherapy and chemotherapy in high-grade gliomas. And in low-grade gliomas, we have many patients with more than 10 years after a complete resection, free of tumor and in very good neurological condition. I think we as neurosurgeon must try to remove completely this kind of tumor. I hope you could understand my presentation, and I think it is all for today.
Well, thank you, Roberto. We could certainly understand you very well, and your slides are excellent. I can see why you're a frequent presenter at international neurosurgical conferences. Thank you very much. And why don't we start the questions off with Rick. Rick, do you have any questions for Roberto?
Right, it really is a nice presentation, and I'm impressed on all the quality work that has been done. We do not have intraoperative MRI, and for eloquent areas we sometimes choose to do awake surgeries. And well, one of the questions is, should we try to combine intraoperative MRI with awake surgery, or are they two different categories of patients, or is it just an add-on? Then do we have to combine everything or switch one for the other? That's one of my questions.
Okay. I think it's very good if you could combine everything. If you have intraoperative MRI, neurophysiological monitoring, if you can operate a patient awake, I think it's better for the patient if you can have everything of you can need. But personally, I don't like awake surgery with awake patient. I made more than 20 cases with awake patient, but I don't like because the anesthesiologists, in my cases, of course, anesthesiologists are afraid. Anesthesiologists are worried, the patient's tired, and the surgeon could be in a hurry, could be working quickly, understand me? And when we use awake patient surgery, mainly in tumor located in Broca or Wernicke area, but after do several surgeries with the patient awake and intraoperative MRI, both at the same time, we view that when the neurologist said to me that we are close to the Broca area or Wernicke area, we was working in the tumor. I could see in the MRI that we are working in the tumor, and sometimes I prefer to give credit to the images more than the neurophysiological stimulation. Actually, I think you have to use your technology or the technology you can have disponible. But I prefer nowadays no operate awake patients. Only because I think I can replace it for intraoperative MRI. But when we began to operate, we use awake surgery, and it's possible. Is a good technique if you don't have MRI. But I prefer MRI, neurophysiological monitoring, and with the patient sleeping during the surgery. Nowadays we are operating in only in exceptional cases, in patients, in reoperated patients, with the patient awake, but not in all of the gliomas.
Okay, thank you. I think indeed that the fatigue is the problem. It takes too long then, and then it's difficult to continue. So usually in awake surgery you have to operate quite quickly, and if you have to add the MRI, then it might take just too long, and it's only a couple of patients that you can really operate on awake, because not everyone is indeed a good candidate, and then it's troublesome to continue. Thank you.
Oh, thank you for you.
Thanks, Dr. Herrera. We have a question from Slaven.
Thank you very much.
His audio is not too good, so he can't talk. What are the most common tumors that you encounter in the supratentorial space?
Excuse me?
Yeah, what are the most common tumors that you find in the supratentorial space?
Supratentorial space?
Yes.
What kind of tumor?
Yeah, tumores más común. The tumors most common.
Yes.
Sí.
We use intraoperative MRI only for glioma, and in some cases in cavernomas located deeper into the brain, but we use MRI in glioma surgery, not in meningiomas, not in another kind of tumor. Mainly in gliomas and in some cavernomas.
Okay. We have another.
And two, and in macroadenomas of the hypophysis, we used to, but nowadays we prefer the endoscopic surgery, and we don't use MRI in all of the hypophysis macroadenoma, but in some cases we use it.
Okay. Another question by Slaven. Do you use awake craniotomy to identify the important functional areas?
Awake surgery.
Yes. Do you use awake craniotomy to identify the most important functional areas?
When we operate with patient awake, we put to sleep the patient. We make the craniotomy, and after that we awake the patient, remove the tumor. After we put to sleep another time the patient and close the craniotomy. The craniotomy we prefer to do with the patient sleep.
Okay. Okay. Very good. Can you hear Rakesh? Can you hear me? Okay. I think he may want to ask a question. Rakesh, can you hear me? Okay. He had to change location.
Yes.
Yeah,
Yes,
I know.
I can hear you.
Okay. Okay. Let's see. Well, it's a very long question. I don't know if I can ask that. Let's see. Well, no, that's okay. That's okay. Well, Dr. Herrera, I thank you very much for a very good presentation, and I certainly welcome you and your fellow neurosurgeons from Argentina to participate in further conferences. And happiness on your travels with you and your family.
Okay, thank you, John, and thank you. Hello, thank you, thank you, everyone. And I promise to send to you a list of many neurosurgeons in Latin America.
Thanks, Roberto. Thanks a lot.
Thank you very much for your presentation.
Thank you very much, Doc.
Thank you.
Thank you, everyone.
Thank you. Fine travel.
Okay, very good, gentlemen. Thank you. Thanks, Rick, for asking questions, and thanks, Slaven. I think we're getting. Rakesh is trying to. Rakesh is trying to connect. Getting a lot of interference. We're getting a lot of interference from your connection.
Sorry, is it okay now?
Yeah, I can hear you now. We can hear you now.
Yeah, I can hear you. I can hear you.
Yeah, unfortunately, I don't know if the doc. Did you want to ask Doc a question?
It's okay. It's okay. It was a nice presentation. I was in between coming and going. It's okay.
Okay, I don't know if he's still there.
Sure.
Nice to have you here, Rakesh. Is my audio still bad?
Yeah, can you hear me, Dr. Herrera?
Yes, I can hear you.
Yeah, okay. We have Rakesh here. We'll kind of finish the conference, but do you want to ask Dr. Herrera a question, Rakesh? He's in India, Dr. Herrera.
Yeah. Hi, Robert. I'm Dr. Rakesh from India.
From India?
Yes, he's from...
yeah, I'm from India.
Yeah. You want to ask a question, Rakesh?
Bangalore, India. Yeah, I wanted to ask in awake craniotomy, what is the most common complications?
Yeah, did you hear that, Dr. Herrera? He said, what is the most common complications in the awake craniotomy?
In a way, craniotomy.
Yeah,
The patient discomfort. I think is the patient discomfort, but I saw some surgeons, neurosurgeons that do away the craniotomy with the patient awake, but I prefer to do the craniotomy with the patient sleeping, and then awake him. But I think it depends on the preference of the neurosurgeon. Mm,
okay. ¿Qué es
I,
lo,
I think,
qué es lo
Okay, thank you.
complicaciones, doctor?
have you have you another experience? It's good too.
I don't know. Rakesh, have you seen complications in awake craniotomies? Rakesh, have you?
No, no, I have not seen. So I just asked, I don't have not much knowledge about that.
Oh, okay. Dr. Herrera, Rakesh says he's not seen any complications because he's not done very many awake
Yeah.
craniotomies.
No, I don't have complication with patient awake. But the complication is the nervous state of the team, and in some cases the patient. And you can't operate awake a boy, a girl. You can operate awake a patient with neurological discharge, with a patient with a tumor in frontal area that this patient are not understand neurosurgeon instruction. You can operate awake patient with a problem in his conscience. I think the wake surgery can't be the gold standard of in glioma surgery. I think it could be useful, but not the gold standard, because you can't operate awake elderly patient, more elderly patient. Patient is necessary a patient with some particular condition to operate him awake. No, in all of the patients, you can have the patient awake while you are opening your head or removing a tumor.
Okay.
That's all. I think it's not the first selection, no? But could be necessary in many cases.
Okay. Okay, very good, Doctor. We're going to end this presentation and we'll start in probably 15-20 minutes with another hangout. And Rick, I'll send you the link if you want to come. And Rakesh, I'll send you the link and you can enter
Sure.
if you want, okay?
Yeah, I'll come. I'll come.
Okay, and Roberto, if you want to attend any of the presentations, please let me know and I'll send you a link.
Okay.
Okay, thank you.
Yeah.
Have a good day, gentlemen.
Nice presentation, Roberto.
Thank you.
Very much.
Later.